Patient number 2 is a lovely 50-year-old woman who has a maternal aunt, maternal cousin who had breast cancer. She lost both of her parents to cancer, so she never wanted cancer. Obviously, nobody wants it, but she's very, very healthy, exercises, eats well, de-stresses, and was diagnosed during COVID, obviously, with a rapidly progressing right breast invasive ductal carcinoma. It was grade 3, ER positive, PR negative, Ki 67 to 40%. She did have a T2N1 tumor. She had a core biopsy of the lymph node, and she desperately didn't want to have chemotherapy. She had initially been told that she should have her lumpectomy and lymph node dissection. That was her first opinion. I got a mammoprint on her, not because I didn't think she needed chemo, but I needed some ammunition with her because sometimes there are ER positive tumors that have been sitting there that are in the nodes, and if they're not going to respond to chemo, the last thing you want to do is give chemo and not have a tumor shrink in front of a patient, because we're kind of missing that boat with neoadjuvant chemo. Anyway, got her mammoprint, and it was super high risk, like 0.785. It was like off the charts. And the good thing is, in this patient who clearly, based on everything, needed chemo, I was able to get her to a place where I could show her the science and say, okay, listen, you have a science mind. Here's where you fall on the Richter scale of intensity when it comes to your tumor responding to chemo. And she reluctantly signed up on board, but now she is all there. I saw her in the middle of her Taxol. I think she's got one more treatment, doing her surgery in October. And so far, I can see the RFID chip, the radiofrequency chip in her lymph node, but the lymph node looks normal, architecture's back. I can see nothing in her breast but the ultrasound marker from her original core biopsy. She wants breast conserving surgery based on neoadjuvant chemo data and sentinel node biopsy. With all of this information, having treated her this way, she's probably going to be able to avoid an axillary node dissection, because I will identify that node, dual dye, radioactive tracer, blue dye, get a frozen section, and as long as she doesn't have residual disease in that lymph node, I will be able to spare her an axillary lymph node dissection, taking out only 3 or 4 lymph nodes as opposed to 15 or 20 lymph nodes. Doing neoadjuvant chemo, I get to preserve more breast tissue. And so the use of genomics and preoperative mammoprint with a predictive ability to see who's going to respond to neoadjuvant chemotherapy, I think is one of the most underutilized tools that we have in our toolbox as breast cancer surgeons, because we have the opportunity to look at the breast, look at the patient, look at the tumor, understand the biology. I mean, my chief of surgery was wonderful. Even though he had a daughter who was a radiologist, he said, surgeons finish at the top of their class, and there's no reason why you shouldn't know the science and the data as well as your medical oncologist, as well as your breast imagers, as well as your radiation oncologist. Patients start with you, they follow up with you. You are the captains of the ship. We are the ones that are running tumor board with our NAPBC multidisciplinary conferences. And it's not because I'm trying to tell oncologists what to do. I'm trying to be the cheerleader and the backup for all the treatment we're about to give those patients, so that they know that we're all on board. And what gives me the ability to do that is genomic testing and having a mammoprint that I can know will predict the patient's outcome.